And then, as you know, that's the fourth meeting we have, as some of you know. So that's the fourth meeting we have this year on that on the longevity rich ecosystem. I think I know everyone, but I'm going to introduce myself again. And then I will introduce what is Compassio and the ecosystem. And then you go to the agenda without further delays because we have a lot to cover. Mhm. I hope you can see my screen. If not, just let me know. Again, it's always open for discussion, so feel free to jump in and make comments, or if you prefer to hold until the end, and then we can discuss as well. So as Compassion, we are a group of executives, former executives, and creators of companies that work together to help accelerate and transform established companies, but also new venture, quote unquote, startups that are driven to help more people living longer and better lives. The way we do it, we do believe that it's important to have a deep knowledge on certain industries, but also being able to make knowledge flow across the different industries and across the different geographies. Compassion is a deviation of the word compass in German, and that means that it's what will help the knowledge flow across the different areas. It's a experience-based approach that we have, so meaning people that have quote unquote the dirty hands on executing things. Uh, as I always say, so we like to read reports, but we like even more to implement them. So we are execution focused, and we, as much as possible, we try to bring global perspectives in each of the projects that we have. Who do we have in the group? Right now, we are 40 people. We have two legal entities, one in Germany, one in Brazil. We are spread across the different continents, either directly or through partners. And then the way we are trying to do is always try to shape the way we can help companies grow, either in their market or to expand to other markets, but also find strategic partners or also find new business models. That's the way we work. And what we always say is that it's about doing and not just saying. As I said, we have a lot of fun when we are able to execute and see the results of the projects coming to life, instead of just sending a theory and tons of PowerPoints to our customers. What is the longevity-rich ecosystem? We found out that we've been observing how much longevity becomes a fancy word, but what is behind of longevity? We know that it's a lot about behavioral changes, demographic changes, but also we know that science has come a long way so far. But what we see as more and more in the markets is the challenge on the last mile, which means, is this product the right fit to that market need? Is this product commercially viable? And that's where we try to focus more. So we have in our group innovators and founders, commercial partners, meaning distributors or people that somehow want to sell something somewhere, investors and experts. And what we like to do, we like to share knowledge, we like to build connections, we like to make companies grow, and we like to accelerate them commercially. So the metrics that really important for me is this. So since January, we have two ongoing fundraising from some of the companies in our network. We have one joint program being developed by four people in our group, and we have one totally new venture being discussed. So that's really let's get out of the talk and let's get to the doing. So that's what we like to do. What is our journey so far? As I said, we have a balance of innovation, but also a good management practice. So in January, Adriana opened our year with talking about systems thinking leadership. Adriana is the founder of the Brio Institute. She brings systems thinking leadership to life. And she also offered the possibility of some of our members to join some of the cohorts they have with a special price. So it was good. But also that was in the middle of the time we were discussing the innovations that were brought to Medica in November of last year, and also what we saw early in January during the Consumer Electronics Show in Las Vegas in 2026. Then in February, Ana and Carlos, they brought consumer insights, specifically focusing on what we call nodes, meaning new older living trends, what is the specific group are looking for? They are digitally savvy. They want to live longer. They want to change their employment contracts, for example. So this discussion was very helpful, not just for the traditional healthcare, chronic disease management, but also across the different industry segments. And Edwin, in March last month, Edwin he brought his approach on building brands, a proprietary approach he has out of a Breath Collective, and try to educate us how we can approach a company, a brand, or a product on the longevity segments. He used also the examples of Whoop, Athletic Greens, and Freestyle Libre as three cases of how this process can be executed and can really work for the different types of companies. And now we are here. So that's April. What we're going to have today. Today is our long session. Depending on how time goes, we may stop for a quick break in the middle. But let's see, because we do have a lot to cover. What we're going to see here is a very fast overview of the innovations being discussed on South by Southwest, on HIMSS and WHX Dubai, former Arab Health. So we're not going to go into all the details of the innovation, but much more kind of plant the seeds of what you need to be looking at, what you need to think about. Everyone that is part of our Longevity Reach ecosystem will receive the final report. There you have all the details and the companies and the contacts and the websites and etc. Then we're going to have Marius sharing his experience on Dehaze and how he's approaching risk stratification and how he's focused in the different markets. Then Shimon is going to talk about what CBX Therapeutics is doing on the cannabinoids and mental health. And then finally, we're going to have Conor sharing his experience and trends about distribution in the healthcare space and what he's doing in his company. Any questions so far, or can we jump into the content and start digging into what's happening in the world? Good. So the agenda looks like this. So we're going to have, again, a lot of content in 30 minutes. Sorry if I speak too fast, so feel free to add comments. Then we're going to have roughly 45 for Marius, roughly 45 for CBX, for Shimon, and 45 for Conor. So it's not strict time, so feel free to jump in. If one of the presenters prefer to have just questions at the end, just let us know. Or if you prefer to make it more interactively, that's fine as well. Whatever works the best for you. Okay? Okay, so our always preliminary longevity innovation report, why we call it always preliminary, because we do not have the ambition to have the ultimate innovation report. Anything that we do on innovation, in one day it's gonna be old. So that's why we call always preliminary, because every quarter we're gonna update it. Who is in our network, you will receive it in January, the first one. You're gonna receive in 1 or 2 weeks the next report. And that's the way we're gonna do until the end of this year. So what we're gonna see here is big buckets on what is happening on the discovery side, what is happening on the validation side, and what is happening on the delivery of the solution side. And they're going to take you through very different types of solutions, from peptides to hospital infrastructure to pure AI. So that's what we're going to see, because those are the things that are being discussed in those events. I like the quote that I have here. That's from a founder of a company that I talked to last week. I am personally doing a direct mentorship with this company, and her complaint was that she sees that more and more the deep tech start losing attention from many of the investors. Why? Because there are so many new innovations, so many innovations coming on AI based only, which they are usually faster to prove, faster to share, and many times faster to exit as well. So whoever is investing in deep tech, either you have the super big buckets like Auto Labs making billions of money from investors, or you're going to be in the battle of how can I prove my thesis and my product while there are so many other investment opportunities for the investors. But have this on the back of your hand, so we're going to go through this anytime in one of the slides in the future. So I will start with a quote from Amy Webb. So if you do not know her, she's the CEO of the company that manages South by Southwest. She's also a professor at the New York University. And in her opening remarks, she said that for the first time in history, some humans will be objectively better than others. So what you're going to see more and more is not that GPT can do things faster to us, but there are what some people are calling physical AI. So machines helping us do more physically, machines helping us do more on a sensorial side, on a cellular reprogramming side as well. So it's just like a way to brought some discussion. So is it possible or not, and how far we can go with that? One of the first things I want to bring, and you're going to understand a little bit of the flow, is all those things about try to rejuvenate cells. So, and let's talk about stem cells and senolytic peptides. So in the beginning, it was pretty much on the academic side, and the understanding is there is a big gap to the business side. What we see is a lot of discussions on how that can be possible to be bridged better. And we see companies like Eli Lilly get into this space. And if a company like Eli Lilly, they are putting their money and hands on this, is a deep pocket distribution process and approval, a lot of money for approval process as well. So some of you asked about what are the congresses or events that I need to look at. I just list 3 of them that will happen in May, if you like the topic. But again, the big thing is how can we move from something that for a system that uses it to manage the disease and try to manage the longevity. So that's a big challenge that I hear from many of the founders. So how can I approve a new product that's going to claim that they help people live more and not to solve an identified process that has a code as a disease worldwide recognized? The other point I want to bring here is an example a little bit similar to that. So also on the senolytic side, there is a combination that was discussed in Dubai, which is a mix from a cancer drug with a flavonoid that is being tested in animals and start being tested in humans.
Olá.
Hello. Okay, good. And the challenge that's also being discussed is on the governance side. So what are the thresholds that the speed of approving new discoveries and new tests and new what was off-label before and a new combination that has a new use, what's going to be governing this? So how can you avoid this being a solution that's going to just reach the high-end side of the population, but also being able to be approved for a broader part of the population? Then a lot of the discussions are also happening on how AI is being applied to drug discovery, and is also understandable that it's already being used and speed up and eliminate the bottleneck that we had on the human side of the drug discovery. And we have right now 173 AI-based drugs going through clinical trials. And the example that Eli Lilly, they have put 2.7 billion on this area specifically. So again, when it's something done on the academic side, when it's something done by 1 or 2 startups is one thing. But when a company like Eli Lilly put money behind of this, something's going to happen. And that we're going to hear more about AI on drug discovery. But then the question remains, well, what's going to happen on the approval side and on the distribution side? Also, a little bit on the distribution side, companies are not just trying to create new solutions, but they also try to rethink the way the solutions are delivered. So this is an example of what Orion Therapeutics is doing. The same way they can deliver RNA solution for certain conditions, they are mimicking the biology of like a virus, for example, and the different elements that can make this being more absorbable by certain parts of the body instead of being running around the body. So that's their solution. They were in one of the startup pitches doing it South by Southwest. But something even more practical is like what Rhea Diagnostics is doing for preterm birth. So taking to home testing so people can see the potential risk of a preterm birth and how they can anticipate and avoid the complication of that. I like the other example. That's a good segue for what we're going to share in one of the slides in the future, or also physiotherapy. So how you can do physiotherapy at home. And this is the example of AT-Dev Reflex.
Bend as far as I can for 3 seconds.
So it's pretty much a device that learn what is expected in the therapy,
I just hit 4
and then
degrees of
guide you through the
extension
therapy
and
process as
115
well.
degrees of flexion. And then I can go ahead and move on to the next activity. which is measuring my strength. So with this one, we're going to measure first quadricep and then hamstring strength. So hit the strength button, go ahead and hit play, extend my leg. The orange circle grows as I push harder, push, 5 seconds, and then bend.
So, Gabriela, I believe you're going to see that physiotherapy is going to be on a challenge very soon, right? So then the other example, which is the human augmentation. So, and I like those three pictures here. So the first picture, if you recognize, this is the kickoff of the FIFA World Cup 2014 in Rio, in which someone was using an exoskeleton and also a brain-computer interface that was developed by the Walk Again project that has the Duke University. And if you see, what is the exoskeleton? So there was a big machine. The guy had a lower back paralysis, and he did the kickoff just by pretending he was going to do the movement. And what we have here below is real cases that was tested last month by Gabriela and by Rafael of a commercially viable exoskeleton. So either if you want to go to Everest or if you just have a heavy lift to load to lift on your work, or if you have 80 something, 90 something years old and you need to have a better stepping to go back your home, there are solutions already commercially offered. Gabriela, I'm not sure if you want to share. So you're the one, the model being testing this here. Let me quick go to the next slides, and then so I can pass the ball to Marius very soon. So, but thanks, Gabriela. So the other topic being discussed is what they are calling emotional outsourcing. So you may have watched or not the movie Her, in which the man got fall in love by the AI. But a number that I had no idea about is that 49% of Gen Z in the US are quote unquote forming any type of relationship with an AI. What is this about? It's not just kind of a chatting, but it can also have the risk of impacting our own cognitive sovereignty. So this is scary, but how can we get the good things of this and avoid the bad things of overusing AI? The other big trend that we see is more and more the use of wearables to additional analytes. So yesterday I was having a discussion with an investor in which we were talking not just about CGM, continuous glucose monitoring, but also the CGM plus, meaning continuous glucose monitoring plus something else like cortisol or lactate or ketones or CXM, additional measurements that you can have. Just to give an example, the question that I had from the investor was, is it expected that the CGM Plus will become the new gold standard once you have it instead of the CGM? And the answer was depends. So it depends if that's a medical validation of it, if that's reimbursable. The big jump that we saw in the use and the market of the CGMs was when it started getting approved for reimbursement. If you pick something like ketone for especially like a type 1 diabetic, there is a very hard condition called DKA that can be very impactful for the patient, can be life-threatening. So maybe that's something that can be potentially approved by reimbursement. But do I need cortisol? Do I need lactate? What for? The big challenge is going to be the governance that we talked before and how to make it reimbursed, approved. But we see also additional things like specifically ones targeting women's healthcare, like in perimenopause, menopause, or for women's willing to get pregnant, for example, and additional analytes that can be made available. But the first thing is that the super growth of the wearables is allowing this technology to be closer to the consumers and potentially some improvements to be able to measure additional analytes. Is still on the wearable side, a big announcement that was done by Verily and Samsung. Not sure if you know Verily. Verily was created by Google in partnership with companies like Roche. Verily, they developed a continuous glucose monitoring that was implantable some years ago. But the good thing on this partnership is that remember that I mentioned about AI being used for discovery. The next bottleneck is going to be on clinical trials. So if you have done a clinical trial already, you know that's not just adopting a new therapy and measure at the end. You need to go frequently to the hospital. What Samsung is offering is that through the Galaxy 8, you're going to be able to measure certain things on the clouds. And with that, being able to avoid the patient to go back to the hospital so often, that can allow additional types of patients to be able to join some of the clinical trials. So that's a big improvement that can potentially help on the clinical trial side for certain conditions. The other big announcement was in Dubai about what is called the formula. The formula goes on this personalized medicine approach. So what they are doing is that based on specific biomarkers, they can take to a compounding pharmacy and deliver a very tailored solution for each patient at home. That was an announcement part of the Dubai Healthcare City. And again, that's taking personalized medicine directly to consumer and at home instead of just being inside of the labs and the big services. The other important announcement was during the HIMSS and what we call breaking the walls or eliminating geographies. We saw in Porto last year some, I think was there were two companies offering any type of monitoring, for example, for patients in senior houses. And what they do, like try to predict a fall or try to see when a behavior was changing, which is actually what Stryker is proposing in the smart hostels to be able to monitor people inside of a room and anticipate some potential risks or see any potential behavioral change. And the same thing I mentioned about Eli Lilly. When you see startups doing something, is one thing, maybe important, but when you see big buckets like Stryker or Eli Lilly getting into this market, it means money to invest in additional development, clinical approvals, and also distribution potential. And last but not least, a challenge that remains very important here, 8 of the 10 drugs, there are 8 of 10 drugs that were put off because of not of causing adverse reactions in women. So we see, and that's a number that I was not, a fact that I was not aware of, that ovary is the fast aging organ in the body and vastly under-researched, meaning to develop something that fits to a woman is still may be specific to them, and there is 50% of the population that requires a specific attention during the discovery and clinical trial process. And that's a very important thing that is yet to be addressed. We know that there are more and more VCs focusing on fintech or VCs focus on women founders, but there is still a big gap comparing to those managed by men. In a quick summary here from the innovations, and again, if you're part of the ecosystem, you're going to receive the final report. In terms of timing, so we see AI going from LLMs to be on the physical AI and infrastructure AI. We see timelines being compressed even further, first in discovery, now in clinical trials, and then in delivery systems. And it's still a big divergency, which is what we are trying to address in some of the discussions in our ecosystem, is how to make things available to more people faster. Any questions so far? No, I'm just 3 minutes late, so that's not bad. Okay, now let's take through Marius first and see how things are going, and then we may do a quick break or go through Shimon, and then we went with Conor. Okay? Thank you. Mario, not sure if you have anything to share. Let me just stop sharing my screen and then.
Amazing.
Good.
Thank you so much, Marcus. Maybe before I start, is there any chance that you write in the comments very briefly what your background is, if you're working in healthcare, if you're working outside of healthcare, working in insurance, just to get a brief understanding of the very specific audience, because then I can tailor the pitch right to that. So that would be great if you can just very briefly put in the comments what your background is. Very nice. So drug discovery, professional coaching, women's health, consulting, healthcare, medtech, finance. All right. Perfect. So I can already see that's very diverse. So let me do the following. I'm gonna show you very briefly from a high level perspective, like more or less in company pitch, what we're doing. And then based on that, we can dive in and just to everyone, please just ask questions in between. If there is anything you do not understand, you have not heard of beforehand, or if you just want to talk about something, because then we can make it very interactively. Let me just open one specific presentation. Here we go. And then I'm going to share my screen. So while I'm sharing my screen, I can already give you a very brief background about myself. So I personally have my background in business, but then also data science in my master's. I'm personally here. Now I think you should see my screen. I'm personally from Munich, have lived in Latin America for more than 2 years, then lived in Spain for a couple of years, started my first startup 2019, focusing on helping our customers to develop healthy lifestyle routines. And then back in 2023, we started with Dehaze. And with Dehaze specifically, we are building an AI model that is capable of identifying risks of chronic diseases early on. And why is this specifically important? And there I want to start with a very brief journey of a patient so that you can imagine what this is actually about. So one of the patients of one of our customers got into the emergency room a couple of weeks ago with not further defined pain in his chest region. After a couple of tests, after 3 hours, the doctor sent him home with the statement, nothing serious to worry about, gave him some painkillers, and that was it. 3 days later, that same patient got back to the hospital being diagnosed with a stroke. And since then, he cannot walk, he cannot talk, and he's laying in the ICU, the intensive care unit. On the one hand, costing a significant amount of money for the healthcare system, but more importantly, having a very significant impact in the quality of life, right? He cannot walk, he cannot talk anymore. And unfortunately, this specific journey is not unique. More than 30% of chronic diseases today still get overlooked. And the reason for that is not that we have bad doctors. The reason for that is that the doctors only have the time and the tools to look at approximately 3% of the theoretically available health data before they make a decision. And this is where we come in with Dehaze. This is what also Marcus beforehand said around risk stratification. What we do, we take the data from our customers, which are health insurance companies that operate their own clinics and labs, and start to map all of that data onto one patient journey. We harmonize that data, and then this patient journey data we put into our own proprietary AI model. And this AI model is capable of detecting outliers in the patient journey, which means you can detect diagnoses that are incorrect. You can detect diagnoses that are about to happen in the future. You can detect also medications that were prescribed incorrectly. Or you can also just predict some general risks of the future trajectories. And all of these insights we then share with our customers through either a web application, a mobile application, or something else. And the magic behind all of this is not how we display the results, but the underlying technology. This is this new AI model that I've been talking about. Important here, it's not just a ChatGPT or Claude or Gemini, where you just enter all the different data points. We actually built our own architecture that's underlying, where we can really take a sequence of health data points in order to then compare them with thousands, millions of other patient journeys. And based on that, we can then identify those outliers. And this really makes us the first right now to be able to work with this unstructured, incomplete, and noisy data and still be capable of predicting the risks of chronic diseases. And there we then have our customers, which are those health networks, the health insurance companies that operate their own clinics and labs. They give us data, we give them insights, and then we have the patients that could be added to this journey as well. So if we then have the pseudonymized data from the patients, we can also approach those patients through our customers, and they can claim their own data, interact with it in order to enhance the risk profiles even further. Now, with that being said, I want to switch from that presentation into the actual product to give you a broad understanding of how that really looks like. So I have prepared some different videos that I want to walk you through. So let me share my screen. Now you should be able to see my screen again. So what I can show you here is we're now in the position of our customers. Our customers usually provide us with the health data of their patients. I now want to walk you through one individual patient, how that would specifically look like. So what we're doing is we're receiving this patient data. Now in our scenario, we're just creating like a text here, which is representing a potential patient in Brazil with 10 years of health data that we would typically receive from one of our customers. Once we have received that, we are processing that specific patient. What does processing mean? This is specifically what I mentioned beforehand with normalizing and harmonizing the data. So what is happening in the background is now we are creating or ramping up all different kinds of AI agents that would go through all this textual data or pictures, images, videos, etc., and would extract different data points. Those data points could be diagnoses, medications, allergies, prior appointments, also social background of all these individual patients. We are extracting that, and through the extraction, we then have the opportunity to also go through all of this. Now, very importantly, this is only a preparation. So this tool is fully internal and not visible by the end customers, but we are just using it in order to understand also the data quality and the ability of us to improve the data extraction, the preparation of the data. What's also important, I mean, if you are working in the healthcare space, one of the core things is interoperability, meaning that you have a chance to actually use some data, map that onto data ontologies like ICD-10 codes, LOIN codes, SNOMED codes, ACT codes, and we're doing all of this in here as well, and we're cleansing the data directly. So as an example here, what you can see is that this specific term would be merged with the other data point that would have an exact match. Additionally, what you can see here is that for the extraction purpose and also the cleansing purpose, we have like multiple AI layers that are judging the quality of the extraction and the normalization. And only if there is a certain threshold surpassed, then we would go into a review process where a human in the loop needs to be included. And this would then look a little bit like this. So now here as an example, we have this specific case where the AI judge said, hey, I cannot judge this anymore. I need to have a human involved. So the reasoning for now having a human involved is also explained directly, where you would say, oh, hey, here is this ICD-10 code, 112022, and the normalized name, which are correct for the diagnosis, but the name field contains a typo. Instead of type 22, it would say type 2. More critically, the source text includes a contradiction and a clinically incorrect ICD-10 code, which means now here the source text would state a typo and it would state an ICD-10 code. However, if we now look into the data ontology, the correct ICD-10 code would be 1122 in order to represent the type 2 diabetes type. And through this, we can really cleanse the data also from handwritten notes, from doctor's notes, in order to then leverage this further for future interaction. And very importantly, we here see also the resolution. So once I, as a human, then review this data, we can accept, modify, reject it in order to also train those AI models very specifically for this individual use case. Now, one of the core things that are interesting thereafter is to also have like this full overview of the patient. So every time we have only one data point, like, let's go back up again. So if we only have one data point of one specific type, we would show this as a box. If it's multiple data points over time, we could also show this as a graph. But we also have like the full timeline in which we would then be able to see, okay, over which time frame that patient would actually have generated those data points. You can really go into all of that depth. You would also see like some social history so that you can actually use these data points as well. Because in the end, all of this will be important when you then start analyzing the patient from a health perspective. And now, very important from a regulatory perspective. Nowadays, nothing is possible with AI anymore if you cannot trace it back 100% to where every decision is actually being made. So this is what we've been doing as well now, so that we have full glass box AI actually tracing back where this patient is coming from, where this individual data point is coming from, so that we can then also include it in the next step. And this next step would now be the following. I mean, as I said beforehand, what we want to achieve is that we get data, we play around with the data, and then predict some specific risks. So this is where now our own AI model is coming in. So within our own AI models, here we have some different versions of those AI models. Here we go. Here we can see that we have all those different AI models that we developed ourselves from scratch. Now, if we select one of those AI models, we then need to upload the patient data. So that would be the patient data we just saw from the other from the other screen. Once we select this individual patient, we then have the opportunity to start predicting those trajectories. And those trajectories would then calculate what are the different risks for changes in lab results, like blood values, then also medications, diagnoses, but also admissions. And all of these would now then be transformed into something actionable for our end customers, those health insurance companies. So also very important again here, this is just to visualize for you in a little bit more depth what our AI model is doing, but this is nothing the end customer actually sees, because this itself does not give any actionable insight, right? It's just in order to make sure that we can talk about this, because talking about an AI model is always very hard if you cannot imagine how this actually looks like. Now, if we again go through this patient, so we've now normalized that data. Now we have run our AI model on that data, and now it's about showcasing the results of this towards the end customer. Here, just as an FYI, this is just a prototype dashboard because every customer somehow wants to see something else. Well, what could we do with the results? Now, here we said, okay, this customer has overall 18,000 different members. This customer wants to understand which patients now will have the risk to create significant costs in the future, because there are some risks of chronic diseases. And then with our analysis, they want to identify those patients and understand what they could now do in order to reduce those costs. So here, what we can show them is that with all the different insights we have, combining this with typical costs of pathways, we can then calculate them some potential cost savings that they could realize if they now follow through on specific interventions. What would that potentially look like? So as an example, here we have 18 members of those 19,000 that should get into a review, like a nurse review, within the next 72 hours. Now, we would give them the opportunity to immediately confirm this, change this, or reject this, but also to review these individual members. What would that look like if we now look into Thomas K, like this 67-year-old, like just FYI, this is all synthetic data right now, just to be sure that we do not have any data privacy issues here. But with Thomas, this 67-year-old guy from Bavaria, we would now have the opportunity to just provide them with a very specific overview of what the risks of this patient might actually be and what the next steps could be that they could pursue. So here, what we would see is there's an acute risk of heart failure monitoring, like a hypertension. And then we would also get like an idea of what would drive this potential risk of this diagnosis. And we would also be able to see, okay, how could we reach out to this patient? And then we can confirm this intervention so that we can then trigger this outreach to the patient to schedule this checkup within the next 72 hours. But very important here is like you still only have a very limited information. For some of them, this is sufficient already. However, what we would then also show them is like this evidence detail. And in this evidence detail, what you would be able to identify again is you would be able to identify what has been the timeline of the past, what also were the signals, so all the different data points that played into this risk occurring right now. And you would also be able to see like the signal cards, like going into more depth around this. And you would have additional insights into there, but this is primarily the core thing that we're driving forward so that our customers would then have more transparency, more visibility, and more conviction to actually act based on this. So yeah, this is a presentation from my side for now, and I'm happy to answer questions from your end.
So Marius, I got a question about the data harmonization, the data inputs. So can you share more about that?
What exactly is your question?
So the question was, what is it? What is the source of the data? So where is the data coming from?
Yeah, so the data is coming directly from our customers. So those health insurance companies that are our customers, they operate their own clinics and labs and therefore have access to the underlying health data. So lab results, MRI scans, doctor's notes, etc. And they can share all of that data with us in a pseudonymized way, and then we can work with the data.
Okay. So any more questions? I do have another ask for Marius to share, but let me see if people, they have questions as well. Hey, Maria Di Mello, I did not see that you joined us. So sorry, I should ask you to provide feedback on the exoskeleton as well. So Marius,
I come late a bit.
sorry?
I started to watch in the end of the presentation of exoskeleton, but this last presentation was wonderful.
Yeah.
Thank you.
So Marius, I know we cannot disclose the name of the companies that you have as customers right now, but I think we had a pretty interesting discussion this morning. So if you can share a little bit about how different players can see the solution, like either as a value-added service or better management of. So if you can share that, I think that's very helpful.
Yes. So in the end, the beauty of what we're building is it's very flexibly usable, right? So in the end, we have an opportunity to normalize all data and to identify risk of those journeys. Now, the first use case we identified was with those health insurance companies because they usually struggle with the high costs they have with their patients that they identify too late. Because if you diagnose the cancer a couple of months too late, number one, there is the risk of the patient not surviving. And number two, the treatment costs usually increase exponentially over time. And that was the first use case. What we then have identified additionally is that you can actually provide these risk scores into multiple different use cases where you could theoretically also help with visualizing lab values that are generated over a specific time. You could go directly to the patient, send them notifications, give them an opportunity to communicate with their health data in more depth. You would be able to also sell directly to hospitals that are generating an insane amount of data that then do not want to identify risks of chronic disease patients sooner, but would potentially want to structure the data better in order to then thereafter start collaborations with pharmaceutical companies to identify patients in a better way for clinical trials, as an example.
Good. So any more questions? I do have more. If no one wants to volunteer.
I have one.
Go ahead.
Yes.
Hello, Marcus. And the question is, who inputs the data and who do the double checks to ensure sure the data is correct?
A very good question. So we, as a company, receive the data through an API from the customer, from the health insurance, from the clinic, from the lab. So this is how we get the data. Then in this normal, and there we also do not have any control over who controls this input of the data, right? Now, what we then do is on our end, we then monitor the quality of the extraction. And this is what I showed with these AI judges. So they potentially see in the text, it would say the left shoulder is in pain, but then they see an ICD-10 code which represents the knee. Just stupid example, but could be, right? And then you would have this difference, and you would then have a human looking over this, also reviewing some other contextual data in order to make sure where is this coming from. And then this is how we then also internally validate that this data is correct. But what we have seen is that like our models of extracting data and normalizing this are already now better than any humans. And this just simplifies the process a lot.
Hey, Marius, we have another question on the chat, which is how is Marius dealing with no standardized nomenclature among the healthcare ecosystem?
Yeah, also very good question, Maria. So this is also the beauty again of AI right now. What we have is I have identified a lot of doctors also just use different abbreviations, right? So some doctors, like if I read it as a human, I would not have any idea. But through this, the AI can now actually go through this, and we have international data standards. So those ICD-10 or now ICD-11 codes or LOIN codes, SNOMED codes, etc. There are public databases that we can use, and they are available in all the different languages. And through this is also then again using the AI judge and this different standardized, like non-standardized nomenclature in order to then check how could we standardize this further. But this is something where these AI agents help us a lot, and that we then also train for each individual customer and each individual hospital of the customer, and potentially even each individual doctor of the hospitals. And through this, we really have very fine-tuned agents for each individual stakeholder in that process. I hope that answered your question, Maria. All right.
Excellent solution. So I think you answered.
And I think
Andrea has
we have another question.
Yeah.
Do you think your system can be escalated to complex health systems where patients can choose in which health structure or lab they do their diagnostic tests and are cared for by clinicians from different institutions? Yes, we do believe this is possible. However, there are obviously more challenges related to that, right? I mean, Germany is a very good example where this is the case, right? You have 120 different public health insurance companies and then still 50 to 100 different private health insurance companies. And if you are insured, you can go to any kind of doctor, etc. And the health insurance companies usually do not have the underlying health data. They only have the claims data. So they would only know this is what the doctor charged from me, but they would not know what is the underlying content of this, right? Now, how do we deal with that? Like, there's multiple different opportunities. Number one, the most beautiful one, however, the most complex one is grassroots approach. So giving this solution directly to the patient for free. They can interact with it. We have a solution out there already anyhow. So more than 1,000 patients are already using this, interacting with it. And on average, they've uploaded more than 250 documents per person. So that's solution number one. However, you really need to find the patients that are really willing to do this, because the majority, in my opinion, would be too lazy to now upload their documents in order to make this work. The second thing is there are usually incentives, or like not incentives, but approaches also in Germany, where you then generate a public health record system. So in Germany, it's called EPA, which is like the electronic health record. Everyone blames it, hates it, etc. However, still there is data ingested into that health record. And we are now working with insurance companies, but also the provider of those health records. And then we have a trained model, a fully trained AI model that could then be placed into this ecosystem. And then the data would not even leave the ecosystem, but it would be executed directly in that system. And the insights, only the insights would then be pushed out, so that then very proactive notifications could be sent to the patient. That's option number two. And option number three is, since we are now training our model with the underlying health data in connection with the claims data, we can also have some surrogate markers, I would call them, where in the future we can also work only with claims data. The results will not be as good as it would be with the underlying health data, but it would already give you a rough estimate of where this could be going.
Yeah, that's fascinating.
Very nice.
Oh, that's a good question, but I think I know the answer, but it's good that you explain. So Marius, just so you know, Marius is in Bavaria, the company is in Germany, but he does have a focus in Brazil, and maybe Mario can share more about what and how.
Yes, so I would definitely be interested, Maria, in running a pilot. Our first three large customers are in Brazil, and also all of our commercial focus is on Brazil. So through that, I'm very happy to discuss that in more depth. And I'm also going to be moving to Brazil within the next couple of weeks. So I can already see your email address here in your name, Maria. So I would just send you an email right after.
Great. Any more questions?
Yes, one question from me, Albert here. Hello, Marius. Congratulations. Sounds like a great invention. I have one question regarding the data that you're collecting, the healthcare data. We know that there are differences between people in different continents and places. So when we look at it from a business side, when you want to scale it to places like Brazil, would you rely on the data you compound from Europe, or would you start with new data that you're collecting in a new market, because there are some differences in the genomics of people?
Yes, very important topic. And also one of the reasons why we start in Brazil. Brazil is the ethnically most diverse country in the world. And through this, if you start training your algorithms in Brazil, you already have a very large overlap with other ethnicities outside of Brazil. Nonetheless, it will be important to always then ramp up additional data sources in other regions in order to then fine-tune the models in that areas. But it already, that's also very interesting. We can already see differences within one and the same country, just from different regions in that same country. So there is a difference when you live in a city versus when you live in a suburban, rural industry, right? Area. So if you live closer to the woods slash having all the noise, the smog, etc., within the city, and then also the difference in the food, the difference in behavior. These are all data points that we would take into consideration, and then it would also start gathering more data points from different regions.
Thanks.
Hey, Marius, just don't tell Bavarian that they are different from the rest of Germany. Hey, another question, Marius. Thinking about your business model, you're going to have a very rich set of data and crossing over different data. So that can become a source of development for other segments or industries. Like if I'm going to develop a new wearable that needs behavior science and also real science, can it also be a source of it? And how do you deal with the data privacy side of it?
Yeah, so I've actually never thought of wearable companies being a potential customers of ours, but rather a data provider. But nonetheless, apart from this, let it be any biotech company, they could become customers of ours because like there's numerous different opportunities we would be able to pursue, right? I mean, the simplest is patient identification, especially relevant for rare diseases, chronic diseases, in order to set up real-world studies, in order to potentially move the therapeutic window further to the front. The second thing is virtual control groups in clinical trials. So we're facing more and more often the issue that we have, or we run clinical trials, or like there are more clinical trials for a specific disease than there are theoretically available patients for the clinical trial. So we need to find other solutions how we can run those and still bring new drugs to the market. And then last but not least, there's the general R&D perspective where you could identify new biomarkers that would act as targets in the future for new drug components. The angle of data privacy is very relevant. So we do not have any data sharing if there's not a full patient consent. And here what we're doing is we get the data from the health insurance companies in a pseudonymized way. We do not share any of that data. However, we then have the chance through our customers to access those patients individually. And if they then start claiming their data, then we can also ask them for consent to participate in some of those programs. This is something where we're also elaborating new business models where we would then have like a revenue share with the patients directly. So depending on the quality of the data they could provide for some of these studies, they would get a chunk of money as well for them, or potentially new tests. These are some things we're still figuring out.
Good. Excellent. Any more questions? If not, then I will ask, I would say thanks a lot, Marius. Great presentation again. So,
Thank you so much.
and we're gonna switch gears to Shimon now.
Hey, hello. Thank you. Thank you, Marius, for an interesting project company that you are building. Hello, everyone. So it's my pleasure to participate here today and share with you what we are doing, how we are doing it, and maybe even why we are doing that. So give me a second to set up.
So I met Shimon in Porto, right? Shimon, so he was with a little table explaining his company. I decided to stop in the middle of the lunch break to see what is that about. So, and I really like what I heard. So
Yeah,
it's good
thank
to have
you.
you in the
Thank you.
group.
One more second. Portion, content, share. 1 second. Trying to organize this thing. All right. Okay. Okay, so my screen is shared. You see the presentation, and today is a very, very nice of Marcus giving me the opportunity to share with you what we are doing at the CBX. CBX Therapeutics is focused on developing novel products based on cannabinoids for different multiple neurodegenerative disorders. We are specifically now working on Parkinson's disease, which will go in a little more details in a second. But given the nature of this these meetings, I would like to actually, and I didn't coordinate this one with Marcus, to ask you a question, okay, to do it just a little bit interactive. So my question is like that. Let's for a second pretend that we're about to participate in a trial, right, in a clinical trial. And the scenario of this trial is there is a tablet, okay? We know from real world evidences that it is safe, okay? It's considered safe. But we still don't have any data in human subjects. We don't know if it's efficient or not. It's open question. On the other hand, there's a lot of research in laboratories, in different preclinical models that signals that there is a good potential for brain health and the preservation of cognition over time. Now, your option as participants in this trial is either to take placebo or to take the active treatment. You choose which treatment you are taking, okay? There is no option not to participate, okay? You have to choose. Either you take the active treatment, you take the chance, or you take the placebo. Now, there is a little, like a little questionnaire or yes or no button that I vibe coded. Whether you can take your phone and scan this QR code, it will take you to that screen, or I'll share in a second the link in the chat, and it will take us like 30 seconds.
Yeah, the QR code works fine. So
yeah, just someone has not a smartphone but stupid phone, Okay, so I give you another like 15 seconds to cast your votes, and we'll get back to it when I like at the end of my talk. All right, let's proceed. So the basic idea is in longevity and in expanding lifespan and health span, and relying on the all the research and knowledge that we have these days. We actually at a point where we like truly can regenerate, fix, or otherwise replace essentially any organ in our body. With one but, which is our brains. It is more challenging to replace it. Wait a second, I did a mistake here with the sharing. Second, my apologies. All right, like that. So the brain is a huge challenge. And this is an introduction. I have several slides on introductory to make sure that we are more or less aligned. So the brain is a dynamic system. Okay, there are multiple different cellular pathways or neuronal circuits. They are interconnected. There is a lot of redundancy. On one hand, But on the other hand, in stress conditions, this redundancy becomes important because they support each other, whether it's in pain sensation, whether it's in emotional processing, whether it's even in our movement coordination. In addition, the signaling is adaptive. It means that different areas or parts of the brain control how other or adjacent parts will respond. So they can increase, augment the response of some other area in the brain, or they can suppress, and there are constant feedback loops that balance everything and give us as a readout our consciousness and our daily mental performance. And on top of it, of all that, there are also multiple different layers of regulation. So neurons are not the only cells in the brain. There are additional cell types, generally referred to as glia cells or the glue cells. They are not just structural elements. They also participate. They are also functional elements. They control activity of neurons. They control the microenvironments of neurons, and all those several tens different types of cells communicate with each other and they respond to each other in bidirectional communication. Now, switching to slightly different is I want to talk with you about the endocannabinoid system. Now we have different systems in our body. Some of them were more familiar, some of them were less familiar. Whether it's the immune system, whether it's cardiovascular system, whether it's gastrointestinal system, and so on. What was discovered about 30 years ago is another additional system. It is the endocannabinoid system. Now, it was discovered as a result of observing that cannabis has effects on us. And not just that the cannabis as a whole, as a plant, but very specific molecules in this botanical source bind to very specific receptors or targets in our body. Now, by definition, our body was not created or underwent evolution so it can respond to cannabis. Okay, same as it goes with morphine, for example. Okay, we were not designed to respond to a plant. We're designed to respond to something that is physiologically present inside us. Now, additional research after identifying that there are receptors for THC to the tetrahydrocannabinol, which is the most most known psychoactive molecule in cannabis. Additional research was investigated. So what actually binds to those receptors? And what was found that there are two major ligands or keys that can bind to those endocannabinoid receptors, to those locks, and open them and activate them. Then the name was coined as endo, which means inside our body, system which respond to cannabinoid activation. So essentially, we have a fully blown functional system in our body that is activated, modulated by molecules that our own body synthesizes, and happen to be that THC, CBD, or whatever other cannabinoids also bind to those receptors. And additional research with 10 years later evidences became to accumulate what this system actually does on a physiological level. So the system itself is primarily a feedback modulation regulating system. What it does in the brain, for example, it regulates the release of neurotransmitters. Okay, it regulates how strong one neuron can interact with the next neuron. It can either increase the strength of interaction or reduce the strength of interaction. Outside of brain or in addition, the ECS, the endocannabinoid system, is strongly involved in inflammatory processes. Okay, primarily to slow down and to suppress inflammation, because in normal inflammatory process, inflammation goes up, and then it has to resolve. There is a resolution of a process, then it goes back to normal. When it does not go back to normal, inflammation progresses and becomes a disease and an inflammatory condition. And the ECS supposed to suppress and to resolve it, to restore back to normal this inflammatory response, which essentially is beneficial and is required for survival or normal function. Those ligands, those parts of endocannabinoid system, also regulate proliferation of immune cells and secretion of different mediators of the immune response, such as cytokines, both in the innate and adaptive immune component, which is like the immune memory and this acute immune response to pathogens. The receptors for ECS were found in every organ in our body, with some differences in the balance between which types of receptors. In the brain, which is our interest, there are primarily more CB1 receptor of type 1 and a little less CB2, and there are two additional types of two additional receptors, but they are not present or much less present in the brain. Okay, I touched more or less on the previous slide about this. So just to convey again that the ECS is a balancing system. It's not responsive. It's not like adrenaline that increases our heart rate, and it's like a flight or fight like framework. It's just balance. If something off balance, it tries to bring it back. If it's under, it tries again to bring it back. So kind of keeping the homeostasis. Now, what begins to emerge that there's also involvement of the ECS in the aging and different diseases processes. For example, there is a decline in overall ECS tone as we age. So the endogenous presence of the endogenous ligands, they named, one is anandamide, another one is 2-AG. Their basal levels start to decline. In the brain, what we see is a weakening of the synaptic self-regulation, meaning that the communication between cells becomes less regulated, and a decrease in endogenous synthesis. Specifically for the neurodegenerative disease, which are characterized as neuronal cell death, we see disruption in the signaling of ECS in Parkinson's, in Alzheimer's, and as well as in ALS. And there is a strong correlation with the pathologic neuroinflammation, loss of specific neuronal cells, such as dopaminergic cells, which are very relevant for Parkinson's, and in general acceleration in the death of neuronal cells. This parameter, obviously, as soon as we identify it, we can intervene and we can try to modify it. So we can modulate the tone primarily with external agonists, similar like we do with the other drugs, that we supplement something that is missing. And this modulation, this intervention in this specific system is extremely untapped and extremely, I would say, novel and pioneering, because the most experience that we have so far with intervention in this physiological feedback loops is through most cases recreational cannabis use, and slowly accumulating medical use, primarily in US, but also emerging to much larger extent in Europe in general as well. And so in CBX, we chose Parkinson's disease on the one hand as a proof of concept, but also a point that we feel confident that we can really help. And the challenge here is compounding, because on one hand we expect to live. I would assume all of us on this call, we expect to reach 100 years old, okay, because of the advantages that we have in medicine in general, in the lifestyle in particular. But in parallel with that, because our brain is ages and we yet to have adequate approaches and technologies to preserve it, it is anticipated that in about 10 years, neurological disorders will become the #1 health span in the healthcare industry as a whole. This particular Parkinson's disease on its own is a major economic burden, estimated in US around 50 billion. And also an important pain point is the Parkinson patients. Most of them, though there is there are drugs and there are treatments, most of them are unsatisfied and go through their life with a very low quality of life, with persistent symptoms. Now, if I'm trying to connect between a new system, like a new physiological feedback loops in the face of endocannabinoid system, and the complex diseases like Parkinson and the neurodegenerative disorders, there is a huge gap that we see, primarily in the in how drug discovery works these days. The classic path is to find a single target and to optimize a single, more specific molecule that will target, that will reach this molecular target, activate it, and hopefully to provide a beneficial effect. But with the explosion of data that we have, and the biological data is expanding, as fast as or maybe even faster than any other information in any other field, is that we see that all those systems in our body, they're in constant communication, and by treating something so focused, like something very narrow, like only reducing heart rate, or only expanding our blood vessels because we want to reduce blood pressure, is not enough. This is not a sustainable solution if we want to improve um, the the health span and and uh, and to target the core, okay, and to target the core of the disease. Many times what happens is that we target something so specific, but we have compensating systems that come in place, and then we need to target those other compensating modalities, and then another one and another one, that you end up with what is called polypharmacy, a person with 4 or 5 different drugs and more. And because just one of them actually treats a very specific like disease or symptom, most of the other ones are just to treat the side effects. Okay, you know, in order to deal with this gap and to look more holistically on a high level, we designed at CBX a discovery platform that relies, which is very common these days, AI, and what was referred to a couple of years ago as ML, or machine learning. Um, that the idea is to find uh, the best biologically active therapeutics which are composed of more than one component. Okay, we do not look at one target at a time. We look on multiple different molecules, orchestrating them together. How can we predict what will be the biological the effect, or how we can combine, and which molecules we can combine together so the biological effect will be superior or synergistic. Like very visually, the way it works is we generate library of molecules. Then this is done in silico. We then calculate all possible combinations. We generate the combinatorial landscape. This combinatorial landscape is then statistically reduced to minimal viable training set. The training set of those combinations then undergoes real wet laboratory experiments. The data from the experiments and then like shuttled and plugged in back into the model in order to improve it, in order to make it better, to increase the score of it being able to predict what will be the readout or the biological readout, and what we ending up at the end of those iterations is simply put as a mathematical equation, and we can solve this equation for for essentially any combination of molecules which we started in the beginning. And I'll give you like a quick example from again from the cannabis plant, in which we have about 150 bioactive cannabinoids. Those 150 cannabinoids can easily generate more than 10 millions of different combinations. Those combinations, after they will go through our discovery platform, we anticipate that will end up with more than 100 different products. Different products meaning they can differ on the composition for the same indication, and they can also differ for the type of indication that is being treated. A very like a bonus from using those large data sets and the IP powered discovery is that it all leads to unique IP. All the combinatorial space can be essentially protected by using a rather simple equation. Okay, and the simple is not like stupid simple. because one of the last equations that we solved had 175 parameters. It's like 3 pages long equation, but this is something very, very tangible that the patent officers at the patent different jurisdictions can digest and can understand what we are asking to protect. Okay, and now like a very simple example from the actual like laboratory experiment is let's say we have a small library of five different cannabinoids, and we want to generate all possible combinations. We need to solve this combinatorial equation. Another given is that we want to find combinations of at least three components, and they can be at 7 different those levels. We solve this equation. We end up with 3,500 completely different options to try. When we run it through the system, through the preliminary sifting in silico, we end up with the system suggesting us to test only 120. And this is very doable in any lab. So those 120, we actually tested them. And the test here was, those were neuronal cells in a tissue culture, in a petri dish. We treated them with those combinations, and we were measuring how much dopamine was secreted. And what you see here is this coding of the number of combination and how much dopamine was secreted. And you very quickly identify here patterns. You already see the active ones. Okay, so this one, for example, is very active. Those are like baseline. And another interesting observation is that you can identify also negative, those that interfere with the process that you want to optimize, and you want to exclude them. And on our side in the lab, we include them in experiments because it helps us to better map this landscape. You need negative results or to find the valleys, and the positive result to find the peaks in this topographical map. From here, you essentially pick out those combinations and you can proceed with them. So this is exactly what we did in our discovery process. We screened, we did like a longitudinal screen, feed it back into the system, solved the equation, found which one was suggested to be like the best one to receive our readout. In this case, it was increase in dopamine. We found one combination that was then verified, obviously, in the cells as well. It ended up with showing a 500% more increase in dopamine from neuronal cells compared to untreated cells. This is just the first step in the drug discovery process. You then need to move to animal trials. In animal trials, specifically for Parkinson, there are two very accepted models that were used in the past by like any giant pharma companies. One of them is looking on how fast and how long the mice can go on a rotating rod, and another one looks at how efficient the orientation of the mouse on a standing pole. They give us indication. There's equivalence to human symptoms. This orientation down is equivalent to bradykinesia. This is slow movement. It's a symptom of PD patients. And the descent down is movement initiation and coordination of the movement. And the rotor rod is indicative of fatigue. So this best combination that graduated from the petri dish was actually very active as well in animal model. And interestingly enough, the gold standard treatment for PD patient levodopa, which we use as a positive control in some in some of the tests, like in this one, and this one was less active than our unique combination. And this was very, very encouraging. What it pushed us to do is to go to human trial. Now, those are cannabinoids, very special regulatory, very interesting regulatory environment. What can be done in US, for example, is we can provide it as a dietary supplement for experiential studies in human subjects. This is not a strict, by the book clinical trial. I must make this disclaimer because of the regulatory environment. But what we actually did, we prepared this product, shared with the volunteers who were ready to and open to try it. This study is ongoing, or like practically we finished it. The data that we collected was based on questionnaires, standard accepted questionnaires that test the symptoms of PD patients across multiple areas in their life, whether it's motor, non-motor, mental, like daily activities, quality of life, and so on. But this is a long questionnaire. We provided our volunteers with the questionnaires before at the baseline, and with another set of questions at the end of this experience journey, if you may. So right now we essentially finishing the study, and we are doing the full data set analysis right now. Just before hopping on joining this call, I was still like crunching the numbers. Okay, so it's happening, it's ongoing. Overall, the feeling is that we also got positive signals from the human participants. So just like again to summarize what we did with this first example of a product is we use this combinatorial AI powered platform to provide us with the most promising candidates to proceed to screening. We screen them essentially in all 3 layers as like a standard or a classic RX product, if you may, from petri dish to animal to human feedbacks. We did already, because of the trial that was ongoing, we did already our pilot manufacturing, so we have all the infrastructure in place, and we are essentially ready to initiate the commercial phase of this process. And worth noting that this is just the first product, and our intention was to prove, first of all, to ourselves, but also to others, that this process, this platform, this approach actually works. Okay, so we can take from something from idea to a real working product in a very short time. It took us a year and a half, and to be ready for a commercial phase. There are additional products in the pipeline that we are working on them right now, and they're essentially stepping along this process. A few more slides is, echoing what Marcos is saying, that he's a doer, not a sayer. So we are planners, okay, and the executors. This is the team that that stands and pushes and works behind the platform, the product, the manufacturing, and everything that we do. Our current focus is to launch the product. We intend to do it in the next 3 months to continue expanding the pipeline. And we are always open and continuously engaging with partners, collaborators, as well as investors who are aligned with our mission. I thank you. We can go, to the questions, but maybe before that, let's go and see what actually happened with this initial question that I asked you guys, and I'll close the loop there. Let's see. Okay, so this was the screen. Let's see if I vibe coded this correctly. This is the admin backend. Okay, so those are the results. Okay, we have 67% favor of a treatment and 33% favor of placebo. Now, the reason why I ask you this question, and this is very interesting, I think is because this underlining understanding that there are a lot of things that we don't know, and many things new will be discovered. But the question is, if we have signals these days, are we ready to take the chance and to be in the placebo group? And I see that the people here, like most of the people here, are not ready to take the chance of being in placebo. On the contrary, they want to be in the treatment. Worst case, it won't work. Okay, but if it does, it maybe will be something very, very interesting and beneficial. So I appreciate. Thank you, and I'll stop my share.
So thanks a lot, Shimon. Let us know if any questions. I do have one question or comments. So my question: how do you see your commercial roadmap? Because I remember when we talked in Porto, you were mentioning about, I think US was your first target country, right? So how do you see that? And also, what are the regulatory challenges that you see to being able to offer in more markets?
Yeah, this is a great question because it's a good question because I'm asking it myself as well. Okay, so you have to be very careful with navigating the regulations around cannabis because it can be tricky. The way we do it is because we have a platform. I didn't mention it because I didn't want to get it more complicated. The data set that we have essentially behaves like a chat interface, and we can ask the data for what kind of product we want. And the reason I'm saying it because our major challenge in the regulatory with interaction with regulatory bodies is presence or absence of THC, the psychoactive molecule. Now we can ask, and we did it. We can ask the data. We want the best combination that does not have THC, and it provides us with an answer. And then we can ask, we want the best combination that does contain THC, and it provides us with an answer. Now, the presence or absence of THC is important because in US, presence of THC locks you to be on a state level. You cannot cross the borders between states. You have to stay in one state and essentially duplicate your operation, copy paste in every state. In a non-THC product, it falls under hemp regulation. It is federally legal. It can be shipped by UPS wherever you want. It can be marketed as a direct to consumer. So we are playing according to those rules. Our first product is a hemp. Okay, so the data I presented you with and the human data is a hemp product without THC, because the idea is with the first launch to be as wide as possible and to keep collecting more signals from real customers in this case. In Europe, it's a country by country regulation. It's slightly more stricter than in US because there's compounding pharmacies and there are physicians that can prescribe cannabis products and others that cannot prescribe and so on. So for us, Europe is on the next phase after we conquer US. And even if we look even further, we do want and we do anticipate to go all the way through FDA process. First of all, because we as a team, we've been there, we did that, we know what they want from us. But this is a much longer time scale, and the funds that you need to have a product go through all the clinical phases there are like multiple times higher than we need for being on the dietary supplement. We see us approaching FDA in about between 3 to 5 years after we collect additional data. And after we collect the real world evidences that keep accumulating, and making it a more compelling case for larger funds investment.
Okay, thank you. Any more questions? Can I keep going? So the other question I have, so in your model, do you see anything that may potentially go directly to the consumer, or it's always expected to be a prescribed solution?
Yeah. So we intend so the strategy and then the tactics implements the regulatory strategy and the commercialization strategy. And the way we operate at least in CBX, we funnel those as a requirement into the R&D department. Okay, and so the basic requirement at this stage was we want a product that can be federally legal and can comply with direct-to-consumer requirements. And this was part of those solid red lines that R&D couldn't cross. So then what happened that the composition of the product was guided by those initial like beacons. Those are the targets. And the product at the end is already compliant with all the requirements because it started as a compliant product, like research, as a compliant R&D. Okay, so we keep this very strict.
Okay, good. Well, thanks a lot. So if there are no more questions, then I should shift to Conor then. So let's move from Israel to Ireland. Thanks a lot, Shimon.
Great. Thank you very much. Hello, everyone, and thank you, Marcus, very much for the invitation to present today. It's a great opportunity, and I'm privileged to be able to share some of my insights and experience, I think, with this particular group. I have had the great pleasure of working with Marcus and Andrea actually in Abbott. We all worked in Abbott for several years. I think we go back maybe 10 years. Marcos and I were on the global marketing leadership side, and I moved to the dark side, I suppose, commercial leadership, which Andrea also did, moved from marketing into commercial general management, which I did myself too. So that was a great time. Unfortunately, the stock price is not doing so well at the moment, I think you can see. But in any case, just while I'm sharing this, I haven't used Zoom in quite a while, actually, so bear with me. The focus of this particular conversation today is really, sorry, let me just go back so I can see everyone. Yeah, is really to share, I suppose, insights and trends and what's happened with medical device and diagnostic distribution over the past few decades and where we are now. You know, the title here is EMEA, but to be honest about it, much of what I'll talk about is pretty, you can draw parallels in Latin America and also in the Asia Pacific region in the indirect spaces. So what I talk about really, it's similar all over in the indirect regions. And just on that, thanks to Marius for asking who's in the group, because I don't want to take anything for granted. And if I just a brief explainer 101, when we talk about distribution in medtech, the label distributor probably downplays the role of these indirect channels in medtech. These are dealers all over the world where in big medtech and in startups, the go-to-market model is generally either direct or indirect, and the direct sales teams will be in the usual suspects, as we'd call them. So the main European countries, the Americas, North America, Canada, and the larger countries in Asia Pacific. In a lot of the rest of the world, so Eastern Europe, Middle East, Africa, LATAM, and some countries in Asia, these medtech companies go indirectly. So they work through dealers. And they might have nobody on the ground working with the dealer, or they may have some employees working on the ground with the dealer. It depends. But I just wanted to share that context. So I'm focusing today on the indirect channel, and Middle East and Africa really is where I'm kind of coming from. So I suppose I'm going to talk about it. I mean, the story really is a kind of a stage one where the problem was created, where many years ago, in a way, OEMs almost kind of engineered the fragmentation, the enormous fragmentation that we see in this ecosystem. The stage two is where the problem has been compounding, and now stage three, we're coming into an opportunistic phase, which I'll talk about in a moment. So the constraint in medtech distribution is no longer really innovation or access as it traditionally was. The constraint is in commercial execution. And I know that I think I saw this on the KOMPASSIUM website somewhere, that it's about commercial execution. So there's strong alignment really here in what I'm doing and the some of at least of what KOMPASSIUM is aiming to do. As I mentioned, I worked with Abbott for about 10 years. I worked with Aerogen, which would be the darling of the Irish medtech indigenous industry. I'm based in Galway in the west of Ireland. And Ireland is interesting in that it's a huge global hub of medtech and pharma, actually. So 19 of the top 20 medical device and pharma companies are based in Ireland. And many of them, in fact, are headquartered here. Medtronic, for example, its global official headquarters is Ireland. So many companies have kind of back integrated into Ireland because of corporation tax, talent, English speaking, access into Europe, etc. So I've spent many years with multinationals, large and small. I've been on the commercial leadership side for 20 or so years, managing large networks of distributors. And when I say large networks, there could have been 80, 90 distributors or dealers in my network at any one time. So it's complex and it's fragmented. I've spent many years on the ground in these regions in the Middle East, in Eastern Europe and Africa, working with distributors and working with founders. And now with my company, Glass Medica, I'm consolidating distributors across MENA specifically, and I'll come to that. So I suppose stage one, the problem was created either by accident or by design, where the OEMs or the manufacturers, whatever you want to call them, I call them OEMs, the manufacturers kept the distributors small. They split territories at country level on purpose. They refused exclusivity at scale. They tended to play operators against each other on price and portfolio. And the objective really was about control. It was about preventing any one partner from becoming too powerful in that they would own the customer relationships too much or perhaps resist being replaced by another distributor. And the result today is you've huge numbers of distributors in some of these markets. You've over 600 in Saudi, over 200 in Morocco. A small country like Jordan has over 150, and so on. And as McKinsey would say, multinationals have gotten trapped into exclusive distribution relationships, producing mediocre results and limited market visibility. This market visibility is really key. This transparency into commercial activity is a big issue for the multinationals. Still in stage one, I suppose it was built for a different world, these distributors, and a lot of them are now approaching exit. So we've a whole generation of founders who own these distribution companies in the Middle East and Africa. Usually they would have been engineers. They set the companies up in the 1990s or 2000s. They worked with what they could, but succession planning is a problem. It's a real problem. So these owners, many of whom, well, some of the thousands I've met, they are either passing it on to one of their offspring, who may take the business on, possibly reluctantly in many cases, or they've nobody to pass it on to. So there's a succession planning crisis in many of these distributors. But at the same time, they have a desire to leave a legacy. They want to protect that reputation that they built up so carefully over decades, and they want to protect that. However, exiting is tricky because they tend to be too small for traditional private equity valuations. And then really the window for this crisis, the succession planning crisis, is from now until about 2030. A lot of these founders are reaching retirement and are looking for a way out. At the same time, the expectations and the requirements of the OEMs are compounding. So, multinationals are getting much more needy in terms of their requirements around tender management, coordinated bids across countries, around pricing governance, compliance certification, anti-bribery sanctions, all of that, and multi-market reporting. So the capabilities of distributors are remaining pretty static because they're not really evolving very much, whereas the manufacturers' requirements are getting bigger and bigger. Let's talk about a couple of countries as examples. Saudi Arabia, for example, where the distributors have essentially become the gatekeepers. The Saudi FDA have made some various regulatory changes over the years. So the local distributor has moved from becoming a distributor, as I say, to being a regulatory gatekeeper, owning those regulatory certifications. So foreign OEMs cannot self-register. They must work through a distributor in Saudi. At the same time, NUPCO, which is the central procurement body in Saudi, 54% of the medtech business goes through NUPCO in tenders. So if you're not in, you can't win. So distributors that can't demonstrate local value in Saudi will lose tender access. And of course, from the manufacturer perspective, changing a distributor mid-cycle could prove very costly, and one could lose out on years of revenue in Saudi. Country case 2 is Morocco. I was there last week, actually, meeting distributors. I'm going back to Saudi next week, in fact. Fingers crossed the travel will be okay. I'll be in Saudi and Jordan and UAE. But in Morocco, there's a whole wave of consolidation happening with the top tier of distributors. So the top kind of 6 or 10 distributors are actually being bought out by funds, by major funds. And that wave 1 is nearly complete. So my point is there is consolidation in some of the markets. There is consolidation of some of these distributors happening already. And the problem of fragmentation is compounding. In many of these countries, oddly, I've learned the customer base is actually fragmenting. We've a lot of emergence of smaller clinics, ambulatory and outpatient care clinics. I mean, they're growing at 10 or 11% CAGR across EMEA, but actually there's a lot of fragmentation across them. At the same time, we've been seeing this in the earlier sessions today. The product is about upgrading beyond moving boxes, connected devices, AI-enabled diagnostics and therapeutics are absolutely key. And the distributors of today, very few of them are equipped to deal with that joined up connectedness of devices and diagnostics, and that's a challenge. As I said, there is capital arriving. There's capital arriving into some of the countries in terms of consolidation. I talked about Morocco. There are a few notable consolidation efforts happening. One of them is the Palex Group, which is based in Spain. They acquire distributors of kind of between 20 to 100 million of revenue. They're focused on Southern and Northern Europe at the moment. We have AGBL they're based in the Gulf region, and again, they're a traditional acquisition model, and Sigala Healthcare as well. They're not so much about acquisition. They're also based in the Gulf in Saudi, but they are partnering with distributors as well. So there are a small number of emerging players in this consolidation space, and on the bottom right then is my own company, which is, to be honest, early days, it's embryonic, but very ambitious plans over the next 5 years to consolidate distributors in the Middle East and Northern Africa. So let's talk about, let's kind of just take a side step for a moment and just imagine you're the owner, the founder / owner of a distributor in Saudi, let's say. So for example, I'll be meeting Dr. Ali Samir next week. He's pushing on. He's about 60. He's built up a nice business. It's probably 8-9 million of revenue. How does he see things? And this is really what I've observed, having worked with these guys for years. He's thinking that from his perspective, I built the relationship with hospitals, with systems. I built the relationships with hospitals. I built the relationships with the OEMs. It's built very much on personal relationships. So if I, as the founder of this company, if I leave, well, then I'm concerned about what will happen. I don't believe, as the owner of a distributor, again, sitting as the owner of a distributor, the risk sharing is not equal. I, as a distributor, take most of the risk, but the Medtronics and Strykers and Abbotts and J&Js of this world come down heavy on my neck. They take no risk, and they fund very little of the activity. I take all of the risk, but the threat of my contract looming is just around the corner all the time. The working capital is a challenge. I might win a Saudi tender in Q1 and I might not get paid until Q4. And I fund that inventory. I fund the accounts receivable. That working capital is all mine. I could have 1 million or 2 million tied up in that, but the OEM, the manufacturer, doesn't care about that. They just want their numbers. Sorry, just on the risk sharing, just a little story. I was in Lebanon just before the war started, actually. There's a good friend of mine owns a company like this. She took on a distribution company from her father in diagnostics. And she told me then after, just as the war started, actually, I was speaking with her and she was talking to the multinational, one of her suppliers, and said, look, Beirut airport is risky, it's dangerous, it's very hard to get product in here. There is a market for the products and I can get paid in Lebanon. They do get paid, believe it, whether it's through, anyway, let's not go there. They do get paid. And she said to the manufacturer, a big medtech company that most of us would know, will you take can we share the risk? So if the product comes in and is blown up on the motorway from the airport into Beirut, or something happens, can we share the risk? The answer was no, absolutely not. So she did and continues to take on the full risk of the challenges they have in Lebanon for the product getting in. So it's very much a David and Goliath situation here, but unfortunately, Goliath doesn't give much away, and there's an imbalance in power, in risk, and in capital. What else do we have? So the next generation, they're not necessarily the answer. My offspring, if I do have offspring to take on the business, they mightn't want it. The relationships aren't there. They're very young. Maybe they've just left college. It's a long road to them really being experienced enough to take over the business. And then finally, the trust is low between myself and the OEM. I don't fully trust them with what I know. The relationship runs on partial disclosure, and both sides understand that, but that's an imperfect situation. So that's kind of where I am from a distributor perspective. I'm in a weak situation. I fund the business, and it's a fragile business, and I work really hard to make it work. And then from the OEM perspective, what are they looking for? Andrea would be very familiar with that. This and Marcus, anyone who's worked on the commercial side with a medtech multinational would understand. They're looking to hit the number. They're looking to hit the number. They would like not just to hit the number, but it's very important, especially to the Abbotts of this world, for example, that what you say you will do, you do what you say and say what you do. That you deliver the number that you say you deliver. They want predictability. They don't like lumpy revenue. They don't like unpredictability. They like consistency and predictability. And that's very, very difficult to provide in these challenging regions of so much turmoil and socioeconomic and political challenges. So what the OEM needs, they want and need that transparency. They want less fragmentation now. There's definitely a move now to having fewer distributors and having more individually governed regional partners instead of 20 or 30 kind of opaque country relationships. And also, they would say this, they want a commercial partner who develops the market, not just fulfilling it. They need partners who develop the market, develop the access, bring together these different product lines and portfolios, particularly as we look at the connectedness of devices and diagnostics. They need a partner who has that sophistication and knowledge to bring that to market. I'm coming to the end of this. You'll be glad to know. I suppose what is it we do then? Glass Medica, we solve these problems, these structural gaps in MENA medtech. So the fragmented channels, the problem of the OEM governance gap, the succession crisis, and the no exits. These are some of the problems that we solve. And what are we doing about it in practice? You might be wondering, what does Glass actually do? So in actual practice, I'm acquiring several distributors, in the process of acquiring through majority stakes, several distributors in the Middle East and Northern Africa, and centralizing the governance of that consolidation, centralizing it in Ireland. So, at a very high level, commercial excellence would be controlled in Ireland, major account management in terms of the manufacturers, and then the operating companies the distributors would remain the opcos in country and do what they're doing, but just do it better. So acquiring distributors, so not only am I acquiring distributors, but actually in the process of doing it, even though there are many distributors that I won't take a stake in, but that I know well and that I've screened and that I'm comfortable with. So I can help direct business to the right distributor if that's helpful. And ultimately, I'm driving consolidation and commercial excellence centrally, solving the problem from the inside out. I have a big pipeline of companies. I won't go through that. Jordan, Saudi, and Morocco, I'm going through due diligence with 3 companies in those countries and several other in the pipeline. And look, just thoughts for the day, I suppose. The constraint we talked about is in commercial execution. The market doesn't have the infrastructure currently to deliver it as much as it needs to. Consolidation has already started, and manufacturers need to partner with those in the know. And OEMs, I believe, I know, they are willing to pay a premium to whoever solves this problem of low transparency and unpredictability. There's a premium to be gained out of increasing that trust, giving more commercial information to the OEMs, thereby extending contract durations and bedding down and locking in those relationships better. And then, of course, AI-enabled healthcare is not a threat to distribution. It's a mandate to move up the value chain for these dealers and distributors. These are my contact details and a QR code, which I think should work and bring you to LinkedIn if you want to connect. I'm happy to take any questions.
Okay, thanks a lot, Conor. So as for sure, I have many questions, but let me allow others to take a chance.
I'm not sure how I stop sharing here. Does anybody know? Here, I'll leave it up for a minute.
I think I can stop.
Oh yeah, I see it now.
Yeah,
There we go.
good. So any questions from the group? I can start with my question then. So Conor, one of the things that so we have the situation in which Europe is looking for alternative partners, right? So setting agreements with India, with Mercosur. There are funds for German companies to go to Africa, for example. As you're presenting, so one of the challenges I see, challenge on my side, not on your side, is that whenever we have those companies willing to go to certain markets, and we have distribution consolidation, what is the risk of having too much big fish to negotiate? Because some of those companies, they are not allowed, they are not about strikers and etc. They are much smaller. So, and if they are not relevant within the portfolio, they're not going to be sold. So,
Yeah.
how do you see that?
Yeah, it's a great question, Marcus, actually, and I suppose you've gone to the crux of my own thesis for my company. Actually, the brands and suppliers I want to distribute are not the Abbotts and Strykers and Medtronics of the world. It's actually not, because they're already well tied up with some of the big distributors. But there is the top tier, you know. So for example, in Saudi, there are 2 or 3 big distribution companies. In the Middle East, there's probably 4 or 5. And the risk, as you say, for smaller companies to go to them is that they just become, you know, one pen in a huge bag of maybe heavy capital equipment or diagnostics, and they do get lost. That is the truth of the matter. They do get lost. So I believe there's a sweet spot where the second tier below the big boys, there's an ability there to work. Like one of my targets are actually startups. You know, I'd like to be able to give startups an easy way to access these amazing markets. There's no way they'll get the attention of the big boys. So there is a sweet spot, and that's where my USP is really, where I'm not going for the big ones. I don't want to become and can't and won't be able to compete with the big huge guys. But there is a tier 2 of distributor that can handle and give the attention to those smaller brands and manufacturers.
I'm glad that you're going to work together very soon then.
No, it's true. I mean, like, and particularly with the challenges of the US market, it was interesting to hear the CBX Therapeutics, you know, the go-to market is the US, and traditionally North America would have been actually, traditionally Europe would have been generally the first kind of launch region, and then North America. But the attraction of North America is obviously one amazing homogenous market. Is tainted now somewhat with the access challenges with tariffs and the FDA. So these markets, such as Saudi, North African markets, they're relatively easy to access, and there are companies pivoting to these. They're becoming a lot more attractive than they were in the past. So, for example, you know, if startups want to do clinical trials or get early KOL adoption, I would say to them, look, come to some of these markets, and will get you early adoption.
Yeah, so my saying is that like when I just went to one trade fair, 15 meetings, 6 requests for proposal, all of them or most of them related to help me go to another market. So
Ah,
so
well, there you
that,
go.
but that's great. The other thing that I have here in the back of my mind, so some of the process that you refer to, I saw that happen in Latin America. Like someone is a great engineer, they open their little shop, they start expanding, become a distributor. Now, second generation does not want to take care of the company. They have other
Yeah.
interests and etc. But I saw also some other cases in which they saw that there is an opportunity in the market to go a little bit further, like offering the services to the hospitals, for example. And there is one very active guy. What they are doing, they are literally acquiring installed base from hospitals and partner with the big OEMs. So instead of distributing machines only, they are actually selling almost like a pay-per-use in a lab, pay-per-use big machines like MRIs and etc. That's a different model, but they become then they want to acquire. So there is a very capital-intensive type of model, but that's another process. Not sure if you see that happening in other markets as well.
No, it's a great point. And actually, I've talked mainly about the owners, founders who kind of want to exit, but this generation of people who have taken on their family businesses reluctantly or not, it doesn't matter, but they're looking at things differently. And actually, in talking to that particular cohort of people, and uh, two of my target acquisitions are those people. They're young, they've taken on the businesses from their father. And actually, they actually really like the idea of becoming part of something bigger. They're much more open. They see that they're channeling their own path alone over the next few years will be difficult. And they see a very compelling proposition in being part of something bigger. So I think that generation are into that consolidation as well.
Okay, good. Great, thank you. Andrea?
Yes. Hello, Conor. Thank you so much for your presentation. That's very interesting and really nice to hear you present again after a couple of years. I could ask you perhaps a dozen questions, but perhaps it's better to have a separate conversation for that. But I have two main, the biggest questions that I would like to understand about Glass Medica is the first one. Do you have, are you looking for certain type of distributors? Like perhaps are you trying to look for certain coherence in terms of their product portfolios or the segments where they work across, their countries or regions of responsibility? And the second question is about the role of Glass in terms of the strategic priorities for those distributors. Do you expect that Glass is going to have that management umbrella over them?
Yeah, brilliant questions. The first question, oh my God, what was it?
Is about the coherence across all the different distributors and the segments that they work.
Yeah. I don't have an easy answer to that because, like, to some extent, and you would have recalled this from one of the earlier companies we worked together in Alir, Andrea. I probably don't have the luxury of being super selective in terms of the distributors who I target or who agree to be acquired. So to some extent, I will end up with a little bit of a Frankenstein. That sounds awful, but quite a big bag of portfolio and products. Now I am, I've a diagnostics focus on the one hand at the moment, but I'm also looking at devices. So I mean, there's an easy segregation there. But in each of those categories, they're both enormous. So yeah, I mean, diagnostics lab point of care is fairly easy, and then I'm looking at cardiovascular, diabetes in the devices, and potentially wearables as well. But again, I don't really have the luxury of being too selective. I'll almost take what I can get and then clean them up after.
Sure.
The second question, yes, I suppose you were asking me what's Glass going to do at a high level. I didn't go into it, but the commercial excellence engine across my organization will be really key, and it's actually a very core piece of the business. I didn't really talk about it, but I will be mandating standardized commercial reporting, standardized commercial systems, CRM, tender management, really properly doing tenders, pricing governance, etc. All of those nice things around commercial excellence, I will be driving that very hard at a central level. And the core, from a financial valuation perspective, what I'll be doing, the entry EBITDA for my targets, the entry valuations, their EBITDA of distributors is around 10 or 12%. I'll be entering at. But once they're consolidated, cleaned up, I get commercial excellence in place. I would aim to be exiting or whatever I do in a few years' time with EBITDA up to 15 or 16%. That's really important. A real core piece of the consolidation. Good questions. Thank
Super
you.
good. Thank you.
So Conor, that means that somehow the founders or the founding family, they will still have a stake in the original distributor, right?
Yeah. So you're asking about the mechanism.
Yeah.
Actually, yeah, I'm doing it in a somewhat novel way. I'm not buying these companies outright. How they get paid for the value for the stake that I take in the companies, the way they're going to be paid is they get some cash up front, a piece of it, but the rest of the valuation, the rest of the stake, I should say, that I'm buying, they get paid in equity in my company. So actually, I take equity in their company. In return, they get equity in the global company or the European company. So they become owners. It's almost like a co-op, but not quite. They become owners in the long term, which is brilliant because they have a huge incentive to ensure that all of the goals of Glass Medica at a central level are actually achieved. So we'll be in it together. That's kind of my thesis.
Yeah, no, that's super interesting. So any more questions from the group?
One comment from my side. Also, congratulations to a very good presentation. I really like the business model you're offering, and I think especially for the Arab countries, this is something that can really work. I've no medtech background, I have a pharmaceutical background. I built up organizations in all of the Middle East countries, so to say. We were always looking for consolidated distribution partners. So I very much see similarities in the pharma world compared to what you're saying in the medtech world. So maybe this is something to scale for you in the future because this legacy of companies handing over to the next generation, not knowing what to do, young generation following their own path. This is something I've seen in Kuwait, in Oman, in Qatar, in the UAE, everywhere. It was literally really, really tough. And a lot of things that you said now in your excellent presentation reminds me of the past 14 years that I spent in that region, always trying to find solutions for my company at that time. Yeah. Thank you very much.
Yeah. Well, thank you, Albert. That's helpful actually. I might connect with you. Maybe there's a pivot down the road that we could talk about. Yeah. Thank you.
Excellent. Thank you.
Yeah, great. So any more questions? No.
Thanks again, Marcus. Really appreciate it. Nice to meet you all.
Well, thanks a lot, Conor. I just have 2 more slides to share, and then I think I can give everyone's some minutes back in their lives. Let me see if I find it. Good, thanks, Conor. So I hope you are back to seeing my screen. So that's it for today. So that's what we have accomplished, and that's what we are planning for May. We have Dr. Sylvia. She's also part of our network. She wants to give her perspective of having this more holistic view of patients and how we start seeing the building of those longevity clinics. And Andrea will be in the Milan Longevity Summit, so there will be a chance also to share what she sees there in the market. Milan is another place in which we see some of those longevity clinics popping up. So that can be a very good discussion. And I also have some another yet to be confirmed, another person that does those longevity clinics to join us. So welcome if everyone wants to join in May. It's always the last Thursday of the month. That's it, when we're going to meet again. Lots of catch-ups possible after this meeting. That's great. So, and some good next steps. And last but not least, that's a community that we want to share. Sometimes we are open to invite people from outside. Sometimes we do something a little bit closer. Everyone that joins the community also have access to the reports and to the presentations. This is just in the case anyone wants to join us. All the information is available in our website, or feel free to reach out to me. Okay? So thanks a lot. 30 minutes back to your life. Good time for a quick coffee. And I hope to see you at the end of the month, next month. Okay?
Thank you, Marcus. Thank you.